All right, welcome. If you're a radiation oncology resident, you know exactly how overwhelming breast cancer trials and guidelines can be. So, we're cutting through the noise today. We're going to build a structured, high-yield clinical paradigm that you can actually use, both in the clinic and, crucially, on your boards. Let's get right into it. To dramatically reduce her cognitive load, we are organizing this review by clinical presentation. We'll quickly cover hypofractionation in early stage, axillary anatomy, post-mastectomy and reconstruction, systemic therapy integration, and finally, special cases like phyllodes and IBC.
Section 1. Hypofractionation, an early stage, or as I like to call it, doing less but doing it way smarter.
Okay, picture this. You're on rounds, and your attending throws out this classic curveball. If a patient has a tiny node-negative tumor, say 1 centimeter or less, and they're already committed to 5 years of tamoxifen, do we really need to add radiation? It's the ultimate de-escalation question.
Well, to back up your answer, you've got to pull out the landmark NSABP B21 trial. This massive study randomized over 1,000 of these patients into 3 specific buckets: tamoxifen alone, radiation alone at 50 gray, or both.
And the results are pretty striking. At 8 years, the tamoxifen alone group had an ipsilateral breast tumor relapse rate of 16.5%. But when you add radiation, that relapse rate plummets to a mere 2.8%. So the answer is a resounding yes. Radiation adds a massive benefit, and we absolutely shouldn't skip it just because they're taking their endocrine therapy.
Which brings us to ultra-hypofractionation and the fast-forward trial. This was a total game changer. They compared a standard 3-week course against a 1-week course of either 26 gray or 27 gray. And here's the kicker. While both 26 and 27 gray gave excellent local control, the 27 gray arm actually caused higher late normal tissue toxicity. Because 26 gray completely avoids that toxicity while keeping the cancer in check, 26 gray and 5 fractions is now our brilliant new standard.
Now, what about partial breast irradiation? You don't need to memorize the entire dense consensus guideline word for word. Just use these buckets. For the boards, burn the suitable column into your brain. Patients 50 or older, tumors 2 centimeters or less, and surgical margins of at least 2 millimeters. If they drop below age 40, have positive margins, or have a BRCA mutation, bam, they fall straight into the unsuitable category. Keep it simple.
All right, Section 2, Axillary Anatomy and Management. Knowing your borders here is the absolute key to understanding de-escalation.
Let's rapid-fire some anatomy facts you are guaranteed to see on exams. The anchor for everything in the axilla is the pectoralis minor muscle. For level 1, it's defined as inferior lateral to the pec minor. It's bounded anteriorly by the pec major and latissimus dorsi and posteriorly by the subscapularis.
Then you have level 2, sitting directly posterior to the pec minor. Its medial and lateral borders are literally defined strictly by the medial and lateral edges of that same muscle.
And level 3? That sits supromedial to the pec minor, reaching cranially all the way up to the thoracic inlet. And look, knowing this isn't just to pass a multiple-choice test. You're going to use these exact boundaries to draw your clinical target volumes every single day.
Now, the trial you absolutely must know for the axilla is ACSOG 0011. This practice-changing study proved that if a patient has a T1 or T2 tumor and only 1 to 2 positive sentinel nodes, and you're already doing whole breast tangents, you can safely skip the morbid axillary lymph node dissection. The 10-year data back this up perfectly. We're safely de-escalating the surgery because our standard radiation fields already cover that low axilla. Pretty elegant, right? Moving to Section 3, Post-mastectomy and Reconstruction. Things get a bit more complex when we're dealing with the chest wall.
When you're looking at a patient who had reconstruction after post-mastectomy radiation, you need to know the risk predictors for complications. Hall and colleagues gave us 3 big ones. First, dosimetrically, a V107 over 11% is a major red flag. Second, using bolus shoots the complication rate from 7% up to 42%. And third, this is huge, patient smoking. If your patient smokes, that complication risk skyrockets to an unbelievable 58%. You absolutely have to talk about these factors with your patients and their plastic surgeons.
Next up, Section 4, Systemic Therapy Integration. This is where tumor biology steps in to dictate how and when we radiate. When it comes to triple-negative breast cancer, Keynote 522 is the trial to know. It literally shifted the entire paradigm. It proved we should add the immunotherapy pembrolizumab to standard neoadjuvant chemo, and then keep it going as an adjuvant therapy for about a year. What does this mean for you?
It means you're going to be treating a whole lot of patients with radiation while they're actively on or just finishing immunotherapy.
And it's completely worth it. Adding pembrolizumab gives an impressive 15% absolute bump in pathologic complete response rates. And the best part? It works regardless of the patient's PD-L1 status. It's a massive win. But as radiation oncologists, we've got to stay super vigilant about intersecting toxicities.
Finally, Section 5, Special Cases. We're talking phyllodes tumors and inflammatory breast cancer. You will absolutely get asked about these on the boards.
If you want an easy way to remember the distant metastasis predictors for phyllodes, just think big storm. B is for big tumor, meaning 7 centimeters or more. I is infiltrative borders. G is growth of stroma, specifically stromal overgrowth, which is actually your strongest independent predictor. S is stromal cellularity. T is tumor mitosis. O is for overgrowth again to reinforce it. R is rapid proliferation. And M is for marker of necrosis. If you see any of these on a path report, your antenna should go up immediately.
You also need to know exactly when to pull the trigger on adjuvant radiation for phyllodes, because it's not one size fits all. If they add a lumpectomy, radiate if the tumor's over 2 centimeters. But if they add a mastectomy, you only radiate if the tumor is an absolute monster, over 10 centimeters. Do not mix those two thresholds up.
Wrapping up with inflammatory breast cancer. Usually, the workflow is neoadjuvant chemo, then mastectomy, then post-op radiation. Our modern systemic drugs are so good now that we rarely need pre-op radiation. But it is still an incredibly vital salvage tool. If your patient is progressing on neoadjuvant chemo or their disease is just stuck and unresectable, you can deploy pre-op radiation, often dose escalated to 60 or 66 Gray, to shrink that tumor down and give your surgeon a fighting chance at a clean resection.
All right, I want to leave you with one number to chew on: 29%. That is the overall complication rate we see in PMRT reconstruction. Every single time you prescribe a fraction, decide to use bolus, or accept a dosimetric plan, there are real physical consequences for the person on the table. With systemic therapies getting better and better, we have to ask ourselves, are we going to figure out how to eliminate that 29% risk entirely, or are we eventually going to de-escalate post-mastectomy radiation right out of existence? Keep questioning the standard, trust your data, and keep pushing for better answers.